Beginning with the Quinlan decision and continuing on through Cruzan recently, it's been very well established that competent patients and or their surrogates may refuse any and all medical treatments. But does this right to have control over the interventions done to one's body translate into a right to demand treatment as well, even if the caregivers should determine or believe that the treatment is a waste of time or futile? Well, to begin our analysis of this question, let's look at two cases that I think serve very nicely to introduce this concept of medical futility. First case involved this 86-year-old lady, a retired school teacher named Helga Wangley. Mrs. Wangley was admitted to the Hennepin County Medical Center in Minneapolis in December of 1989 with a broken hip. She had a background history of chronic bronchitis and developed postoperative pneumonia after the fracture was repaired, and this required her to be intubated and go on a ventilator. Because of her underlying respiratory disease, they were not able to wean her from the ventilator, and they continued supporting her in this manner until the following May, when she experienced a cardiac arrest, from which she was resuscitated, but never again regained consciousness. And later, her physicians declared that she was in a persistent vegetative state. Because she was unweanable from the ventilator, and because they gave her no hope of recovering from the vegetative state, they recommended that the ventilator be discontinued, or at the very least, she not be resuscitated again should she experience another arrest. Mr. Wangley, a retired lawyer, was her power of attorney for health care, and he stated that the physician should not be trying to play God, and that it was not in Mrs. Wangley's best interest to be dead. He and the Wangley children insistently reiterated the fact that Mrs. Wangley had always implored them never give up on me and to continue to provide ongoing support for her regardless of her quality of life. They articulated this in the context of very deeply held religious convictions. In February of 1991, the hospital went to court to impeach Mr. Wangley as guardian. Interestingly, they did not appeal to the court to allow them to discontinue the ventilator on the basis of futility, but believed the intervention rather not beneficial. The rationale was that the ventilator was for, number one, healing of her underlying pulmonary disease, which could not occur. Number two, palliation of suffering for terminal illness, and or number three, enabling the disabled to enjoy life. Because she was in the persistent vegetative state, the latter two goals were not achievable. Therefore, they declared continued ventilatory support as not beneficial and did not believe that they should be obligated to continue to provide it. However, because the question asked of the court was about Mr. Wangley's capacity to serve as her surrogate, the court found in favor of the family and the patient and rejected the hospital's request. 3 days after the court gave their ruling, the patient died while still on the ventilator. This case propelled the concept of medical futility into the bioethical arena, and Stephen Miles, one of the physicians involved in the case and also a medical ethicist at Hennepin County, helped define the concept of futility as, quote, an institution which annuls a perceived duty to perform a medical practice based on the outcome of treatment. In other words, are caregivers required to continue to provide medical interventions that they believe are futile? The second case involved an anencephalic baby girl known as Baby K. Stephanie Keene was born on October 13, 1992. Prenatal testing had revealed the diagnosis of anencephaly, that is, an absence of the development of the higher brain or the cerebral cortex, but her mother refused the abortion that was offered her. At birth, the mother requested that all care be rendered for her child because she knew that God would heal her baby. Therefore, a C-section was performed and the baby intubated, and not only was this done to abide by mother's requests, but also to confirm the diagnosis and, more importantly, to allow Baby K's mother a full opportunity to understand what anencephaly really was. Subsequent discussions, however, found the mother continuing to refuse do not resuscitate status, and demanding that all necessary care be rendered to keep baby K alive. The staff and the Hospital Institutional Ethics Committee stated that continuing to provide care for this child without a cerebral cortex was futile because the child would never experience her surroundings or achieve anything close to a fully functioning human life. Now, baby K was eventually weaned from her ventilator and transferred to a nursing home, but she required readmission to the hospital several times for recurrent respiratory problems. The hospital then sought judicial intervention to allow them to refuse to continue to provide this aggressive management when these respiratory difficulties arose. Federal Judge Claude Hilton ruled on July 1st, 1993, that the hospital had a duty to continue to provide full medical care under the Federal Rehabilitation Act of 1973, the Americans with Disabilities Act of 1990, and the Emergency Medical Treatment and Active Labor Act, EMTALA. He did not address a standard of care for anencephaly or what the best interest of the child might be. On December of 1994, the United States Fourth Circuit of Appeals affirmed Judge Hilton's decision, stating that EMTALA did not make an exception for anencephalic infants or anyone else. The case was appealed to the Supreme Court, which denied a writ of certiorari, letting stand the Fourth Circuit's decision on October 3rd of last year. Baby K died in April of this year at the age of 2.5 years. Her mother contended throughout that all life was precious and that God, not doctors, nor even herself, should determine her daughter's fate. Now, in an age where patient autonomy has been established as the main pillar of bioethical discussion, at least in the secular community, is there support for this concept that caregivers can or should unilaterally deny patients life-sustaining intervention? What are the roots of this conflict? And if caregivers are not required to provide all care demanded by patients or their surrogates, what are the criteria for determining which care can be denied? I believe the futility debate has its origin in 5 sources: professional integrity, personal integrity, a backlash against autonomy, economic concerns, and a lack of uniform values in our society. Some concept of futility and the necessity for caregivers to draw limits is part of the historical tradition of medicine. Hippocrates wrote in his piece, The Art, "First, I will define what I conceive medicine to be. In general terms, it is to do away with the sufferings of the sick, to lessen the violence of their diseases, and to refuse to treat those who are overmastered by their disease, realizing that in such cases, medicine is powerless." And later he adds, "When therefore a man suffers from an ill which is too strong for the means at the disposal of medicine, he surely must not even expect that it can be overcome by medicine." The caregiver has always had the responsibility to determine which interventions have the possibility of benefiting the patient and not offering those that do not. There's something more to being a physician or caregiver than being a businessman or a technician. Judgment and commitment to doing good while minimizing harm are a significant part of our long-established medical ethic. Caregivers should not administer treatments that cause harm disproportionate to foreseeable benefit. And similarly, caregivers are also responsible not to fraudulently misrepresent their knowledge or skills, but must openly and honestly discuss the limitations of treatment. Beyond the issue of professional integrity is that of individual moral integrity. Healthcare providers should not be required or forced to provide interventions that they believe are morally wrong or repugnant. Many caregivers believe that performing CPR on a patient who has little or no chance of benefiting from the procedure, such as an individual with end-stage malignant disease, is committing battery. Maintaining ventilatory support and other potentially painful interventions may be seen as cruel rather than as beneficial. And any of us who interact with nurses, therapists, physicians who have been involved in continuing to provide aggressive interventions in cases of patients with irreversible end-stage malignant disease or other end-stage disorders have frequently heard the complaint of a sickening feeling of doing violence to the patient, contrary to the nature and spirit of what motivated them to become healthcare providers in the first place. Moreover, the personal integrity of caregivers has been recognized and supported by the courts. The Supreme Judicial Court of Massachusetts stated in the Brophy case, "There is nothing in the law which would justify compelling medical professionals to take active measures which are contrary to their view of their ethical duty toward their patients." The subjective feeling that one is actually doing harm or wrong in these cases has been a powerful motivator in the push to define futility. Now, there's no question that some who have written on futility are reacting against the ascendancy of patient autonomy. They believe autonomy has run amok, and empowering caregivers the unilateral right to say no is seen as a balance to what they perceive as an abuse of autonomy. It has been well established in the bioethics, medical, and legal communities that patients do have the right to refuse any and all interventions. But it is another issue entirely to propose that they or their surrogates have the right to demand any treatment they desire. Now, even though futility is a concept that reputedly centers only on the outcomes of intervention, the issues of economics and resource allocation inescapably enter into the debate. Lantos has argued that futility was rediscovered with the creation of prospective payment systems in the late 1980s. Now, there's no question the caregivers are more and more conscious of expenditure of effort, machinery, monetary resources in our interventions. And indeed, it should be our responsibility to be good stewards of these resources and not to squander them in fruitless or futile interventions. However, we have to be very careful to distinguish rationing from futility. Just because a treatment is costly does not necessarily make it futile. But what is expressed in these concerns is the perception or understanding that in some interventions the cost, and this is either monetarily or in terms of the patient's well-being, the cost is disproportionate to the amount of benefit derived. Process, not just endpoints, must be evaluated as well. I think it's also appropriate to remember that before the days of health insurance, futility was an understood concept. If a treatment didn't offer much hope of working, it wasn't started or was stopped. People could not afford to do something that didn't work. Now, however, with the bottomless coffers of health insurance, good sense has given way to unrealistic hope and do everything thinking. Ultimately, though, many of the cases of futility come down to questions of our deepest values. Javi Moraim wrote very profoundly in the Hastings Center report last year, "This dispute about whether physicians ethically can or ought unilaterally to refuse to provide life support revolves around fundamentally irresolvable moral conflicts concerning our most deeply held beliefs about the value of life, especially profoundly diminished life." She went on to state, "Thus, the futility debate is itself largely futile. The fundamentally intractable nature of this dispute in turn prompts coercion and the threat of coercion. Where dispute cannot be resolved by rational argument or persuasion, then believers of one side can only prevail on the dissenting others by force." In the two cases that I cited, the patient and or the family maintained deeply held beliefs of the inestimable value of life without any qualifications. These individuals found themselves at odds with their caregivers who did not maintain their more vitalistic set of values. I believe it is safe to say that most caregivers are not vitalists, but have come to believe that quality is an important value in assessing life. To these non-vitalists, maintaining that life at all costs is not a worthwhile goal if the life cannot be restored to some degree of function other than basic physiologic activity. And this shows that our society is a composite of many individuals and groups maintaining very diverse value systems. This diversity inherently creates conflicts, and it is a recognition of this fact that undermines all efforts to empower caregivers to unilaterally discontinue treatment and makes the task of trying to create a just definition of futility that extends beyond the most narrow criteria extremely difficult. So then we must ask the question, can futility be adequately or fairly defined? A good starting place is to go to the origins of the word futility itself. Futility derives from the Latin word meaning leaky, futilis. According to the Oxford English Dictionary, a futile action is leaky, hence untrustworthy, vain, failing of the desired end through intrinsic defect. In Greek mythology, the gods condemned the daughters of Danaus to carry water in leaky buckets or sieves. Regardless of their unending labors, they could never achieve the commanded goal of conveying water from one point to another. Therefore, a futile intervention is one that cannot achieve the goals of the intervention no matter how often it's repeated. Failure may be predicted because of the inherent nature of the intervention proposed. Now, can this understanding of that which is futile be applied in the clinical sphere? The American Medical Association took a shot at it last year, providing some support for the concept, but leaving us with, I think, a discouraging conclusion. They said in the 1994 Code of Medical Ethics, physicians are not ethically obligated to deliver care that in their best professional judgment will not have a reasonable chance of benefiting their patients. Patients should not be given treatment simply because they demand them. Denial of treatment should be justified by reliance on openly stated ethical principles and accepted standards of care, not on the concept of futility, which cannot be meaningfully defined. It seems, however, that there are some situations where it should be very clear that the intervention is futile and therefore not required. For instance, if a proposed treatment has no pathophysiologic rationale, it is, by the definition of futility, leaky, failing of the desired end through intrinsic defect. We don't use cytotoxic chemotherapy for the treatment of coronary artery disease. Similarly, if maximal therapy is already being employed but is failing, attempting to add other treatments won't improve the situation. A third example would be a request to repeat interventions that have already failed. And I have, on more than one occasion, received requests from patients whose malignancy is progressing through the drugs, but they want those same drugs repeated again and again and again. Lastly, if the proposed intervention will not achieve the goals of care, then it is not a valuable undertaking. But it has to be clearly understood that who defines the goals of care to be very important here. If the patient and the caregiver share the same goals, it would be relatively easy for them to jointly decide that an intervention is futile. But these definitions are strict, they're limited, and they don't cover many of the situations in which clinicians would be tempted to use a futility criteria. In fact, if all always agreed on the goals of therapy, this discussion wouldn't need to occur. Probably the best known attempt to create a clinical definition of futility has been proposed by Larry Schneiderman, Nancy Jecker, and Al Johnson. The definition contains two parts. First is a quantitative definition which states, when a physician concludes that in the last 100 cases a medical treatment has been ineffective, it is therefore futile. Now, Schneiderman et al. Admit that this is an arbitrary level that they've established, but they believe it's a threshold with which most would become comfortable. Yet, it hasn't been shown that a 5% threshold or a 1 in 1,000 cutoff might not be more appropriate. And I think it is doubtful that universal acceptance of any given statistical threshold will be achieved. Even more troubling is a reality that many of us have encountered at times in our practices. These are those situations where the odds would tell us there was no reasonable hope, yet the outcomes were positive. And what's even more troubling about these situations is that the treatment was continued in an aggressive fashion because we had some sort of a gut feeling that this was the time to try. This was the one to go after. And yet, this clinical feel is not in any way quantifiable. Yet if we enthrone policies or set criteria where care can be unilaterally discontinued, will we not run into problems from institutions and third-party payers balking on proceeding with our intuitions, our clinical judgment? The second aspect of their definition adds a qualitative notion, stating, when a treatment merely prolongs permanent unconsciousness or cannot end dependence on intensive medical interventions, even if it has some physiologic effect on some part of the body, the treatment may also be called futile. This is the most troublesome aspect of their definition because it is entirely value-laden. It clearly states qualitative life is more important than quantitative life. Now, while the majority may agree with this position, the Wangleys and baby Kay's mother clearly disagree, nor are they alone in this belief. Moreover, this definition is ambiguous. The statement, "cannot end dependence on intensive medical intervention," is nebulous. How intensive must the intervention be? One could accurately define the intensive ventilatory support that the brilliant astrophysicist Stephen Hawking requires in his struggle with ALS is futile by this definition. Yet, we do not define his care as futile because Dr. Hawking has a desire to live and to continue to contribute to his science. Are we then biased because of his brilliance and his contributions? Have we not added yet another subjective level of values unto the mess? And have we not now begun to compare the value of individual lives? There are many problems with the Schneiderman definition, and I believe all definitions of futility. Are our data adequate to determine what is quantitatively futile or not? Perhaps the individual clinician may not be familiar with the depth of the medical literature or have enough personal experience to appropriately gauge the probabilities of outcomes. We're also faced with the problem that as caregivers, we all determine prognosis from our own subjective assessments. Ullman and Perlman have shown that caregivers undervalue the quality of patients' lives. Because of these subjective assessments, futility policies will be inconsistently applied. There's also the fear that futility will be used as a trump card when the major concern is actually one of allocation. But basing the definition of futility purely on outcomes does not convey the importance of disproportionality that I believe is crucial in making medical judgments. That is, balancing the cost of the intervention compared to the potential benefit to be achieved. Thomas Prendergast recently gave an interesting example that I believe illustrates this problem of disproportionality. He referred to a patient with small cell carcinoma of the lung who developed extensive metastasis in spite of chemotherapy. Two options seemed open to his caregivers. The first was to transfer the patient to a hospice where the medical director insists on administration of a special herbal tea which he claims has therapeutic efficacy in 1 in 100 patients. One treated patient improved enough to leave the hospice to live at home for a year before dying. The second option was aggressive chemotherapy with autologous bone marrow rescue. 1 of 100 patients treated with this therapy had also improved enough to live at home a year before expiring. Now, given that the probabilities are the same, and at Schneiderman's 1% threshold, are both therapies equally futile? I think that most of us would have no problem at all attempting the herb tea, but would have a great deal of time giving the intensive chemotherapy and an autologous bone marrow transplant. Why? Because of the extreme amount of discomfort that may be inflicted upon the patient with the aggressive therapy. In fact, this treatment could potentially shorten the patient's life. It would deprive him of the opportunity to receive good palliative care, and certainly it would deprive him of the opportunity to be in the comfort of home. This conveys a sense that it is the cost of the intervention that also must be considered in determining futility. And Prendergast then goes on to state, futility in medicine is not exclusively about prognosis. The likelihood of success is critically important, but so is the process of care. Probability, without mention to process, conveys nothing about futility. It's just a number. One fundamentally unanswered question in this debate is, who gets to define futility? Because only the patient can place a value on his or her life and individually weigh the burdens of treatment versus the potential benefits. Some, such as Bob Beach, have argued that only the patient or their surrogate can determine what is futile care. This approach remains respectful of the preeminence of patients' values, but does little to resolve the dilemmas created when caregivers are asked to provide treatment that they believe is wrong or futile. Therefore, should the physician or other caregivers determine what is futile? As I've already mentioned, physicians subjectively undervalue quality of life considerations and may be in direct disagreement with the value system of the patient. Individual physicians may arbitrarily and inconsistently apply futility criteria at the bedside. This approach, I believe, would create significant risk for violence to be done to some patients' value systems. Consequently, others have suggested that futility can only then be defined by societal consensus. This would help prevent, to some degree, arbitrary definitions by caregivers, but would at least provide some tools for the caregivers to respond to inappropriate demands from patients or surrogates. But the difficulty here is that societal consensus will never be achieved. Ultimately, the majority will establish and impose their values upon a minority. Those groups possessing a vitalistic worldview will be excluded from the whole, and therefore we return to the risk and reality, as Javier Moraine pointed out, that one side will inevitably be coerced in these situations. To me, the great tragedy of the futility issue is the way that most who have written about it insist upon analyzing the problem as a division of power. The power of patient autonomy versus the power of medical knowledge and judgment. This approach fundamentally misses the real power in medicine. The power is in the relationship, the coming together of the afflicted and the healer, blending goals and needs with knowledge and skill to come to as good an outcome as may be possible. There can be no true healing without this relationship. The futility versus autonomy dichotomy pits caregiver against patient. Healing and caring, though, is not a game where one side plays a trump card against the other to win. To resort to the futility card is to admit that the healing relationship has died or is at least severely impaired. I'm particularly haunted by a situation of which I was made familiar. A 76-year-old white male had had partial lobectomies in the past for biopsy-proven adenocarcinoma of the lung. He was now suffering from recurrent malignant pleural effusions and had been hospitalized on multiple occasions for shortness of breath. Chemotherapy had been tried, but the disease progressed through it. During multiple hospitalizations, he had required artificial ventilation until the fluid could be drained from his chest cavity and his breathing improved. He was admitted to the hospital one more time for placement in the intensive care unit and a therapeutic thoracentesis, or draining of the fluid. As in the past, the patient requested full resuscitative measures should he experience a cardiopulmonary arrest, and particularly wished to be reintubated again if necessary. Obviously, he had had enough experience to know what that involved. He expressed that his goal was to stay alive as long as he could. His caregivers, though, realizing his very dim prognosis, believed that coding this patient or even reintubating him in the case of respiratory failure had become futile. He was going to die very soon anyway, so why should we keep subjecting him to the same invasive, painful treatment? They therefore unilaterally made the patient DNR and dismissed him to the floor directly in violation of his expressed wishes. He was alert, very understanding of his situation, and those who related the story to me indicated that he and his family felt betrayed and abandoned by his caregivers. The patient had a cardiopulmonary arrest the next day and expired. What was the good achieved here? There is no debate that the chance of his surviving a cardiopulmonary arrest to discharge was 0, even in the most optimistic report, 4%. But was not performing a 15-minute resuscitation effort worth the sense of betrayal the patient felt? His caregivers did not want to commit battery against this man's body, but what, I ask, of the trauma to his spirit and soul? Now, in fairness, I can also recount equally wrenching situations of clearly irrational requests from patients that force caregivers to continue to attend to bodies that essentially long since died. The caregiver's sense of wrong and outrage was appropriate, yet I remain troubled by the question, how can we establish a policy which will admittedly be arbitrary to prevent those circumstances without just as frequently, if not more so, creating situations like the one I just described? Does our faith have anything to contribute to this discussion? Trusting in God's sovereignty has certainly clarified my own position on end-of-life concerns. I do not believe that Scripture compels us to value life above all other considerations, such is idolatry. We must recognize that there is a time to be born and a time to die, as Solomon wrote in Ecclesiastes. Acknowledging that it may be time to die is compatible with respect for the sanctity of life. Now, clearly, this leaves a very heavy responsibility on us who are entrusted with determining when we should no longer prolong a life that God has created. But I fear, however, that we too frequently are on the side of playing God by artificially prolonging death. While we believe in a God who can perform miracles, I must also remember, as my friend Bob Orr states, God is not ventilator dependent. We should not put God to the test, nor should we expect to coerce him into performing a miracle by our insistence on using artificial interventions. I also recognize that there are those within the body of Christ who disagree with this assessment, and while we differ, I respect them and their faith. I believe it is my duty and the duty of our society to protect their beliefs. Futility threatens to declare that there are groups in our population whose belief system we will no longer respect, and if they differ with us, we will discontinue their care. This clearly cannot be allowed to happen. So what can we practically do about these difficult situations? First of all, I believe many of the demands for therapy are based upon unrealistic expectations about what medicine can achieve. Last summer, Murphy et al. Published in the New England Journal a very interesting study where they took a group of patients, gave them some clinical situations, and asked them if they wanted to be coded if they had an arrest. Then they went back and told the patients, they educated them about what the realistic expectations of outcome from CPR would be in that situation. When the patients learned that information, the number still wanting resuscitative measures was cut in half. And in fact, when they went through and fully educated them about the nature and the outcomes of CPR, the expected outcomes of CPR, the vast majority started changing their interest in whether they wanted to be resuscitated or not. Now, there were a group of patients, about 10%, that even at that 1% threshold, they would want to be resuscitated, and they maintain a more vitalistic worldview. But the lesson I take from their study is that the majority of patients, when they really understand what it's all about, aren't necessarily interested in these type of invasive procedures. So, we should learn that when patients are educated about the realistic outcomes of CPR, those still interested in receiving this intervention will decline in number. We are obligated to honestly share with our patients the potential outcomes of treatments. And we mustn't do the games that we've done in the past by asking, do you want us to bring you back to life if you die? Or, in the event your heart stops, do you want us to restart it? And leave it at that. Neither is the usual scare tactic, do you want us to break your ribs, shock your body, burn your skin, acceptable either. Honest communication, accurate outcomes data. I think these things will help resolve many of the conflicts. Now, I have the privilege and pleasure, as Fred said, of serving on the CMDS Ethics Commission. And my first responsibility on the commission was to begin the work on our statement on futility. And so the remainder of my remarks I abstract from our final statement. Because, as I have mentioned, relationship is key, I believe caregivers should do everything in their means to try to come up with a mutually acceptable course of action. But I also believe the caregivers should not be required to provide treatment that is truly repugnant to them or contrary to their moral beliefs. If, therefore, a conflict cannot be resolved by further discussion or additional consultation, then transfer of care is appropriate. As often in these cases, when transfer of care may not be possible, the requested treatment is outside of accepted medical practice, then in those limited circumstances, the caregiver may be justified in withholding or withdrawing the treatment. But if the treatment is the standard of care, which, at the present time, cardiopulmonary resuscitation for all patients currently remains, then the caregiver should continue to abide by the patient's or surrogate's wishes. In all situations, caregivers should serve as a healing presence of love, care, and compassion.
We have time for a couple of questions. there seems to be a presumption here that you alluded to briefly, that a sovereign God can be conscripted to provide a particular miraculous result, and that not only can that be done, but the instrument of that conscription can be human instrumentation and technology. The second thing, which you also alluded to very nicely, was the breakdown of communication. And I'm wondering, since I have some familiarity with the background of these two cases, where there could have been an opportunity earlier on, in the case of baby K, perhaps during the pregnancy, for some kind of more neutral opening up of the lines of communication, which may have circumvented this confrontational issue that resulted. Because once you get into a litigation situation, that really only aggravates the lack of communication. And in the same way, the case of the Wangleys. Both of these people, both of these cases involving very fundamentalistic beliefs and vitalistic beliefs, I wonder where the opportunity for some kind of moral reasoning or moral justification might have taken place that could have obviated those things. And is there a lesson to learn for future issues where we start to see things setting up in the same way, that this is going to be a head-to-head battle? Where do we turn so that we can back off a little bit and get away from the confrontational scenario that's developing?
Thanks, Jim. Excellent questions. The best that I can project in the two cases was that in both, I believe the families involved did indeed, they were vitalists. They maintained a value system which they felt would not allow them to do anything other than the requests that they gave their providers. And in those situations, I am not sure that there would have been any other outcome other than the fact that the healthcare providers would, in essence, be coerced into continuing to provide it. I personally would hope that they wouldn't feel coerced. I think that I would prefer to see us as partners in this, trying to understand a patient's value system, and even though we may disagree with it, we'll try to work within that framework and let them know that we hear and respect them. And I guess the second part is, what preemptively could we do earlier on? And that's my thought about it, my approach, is before we start walking in and saying, well, we're not going to do this, we're not going to do that, trying to get a feel for what's important to the patient or the family, trying to know their values, and then responding. So that the first thing that we're perceived as doing is not accusing them or not saying you have to do this or you're wrong in doing this. Because if you come in and establish a relationship of respect, then you can at least work through and say, I understand, I respect your beliefs, but can we look at it this way? Can we talk about God in this way? And see if perhaps there is room, for negotiation, for understanding. But as you very well point out, so often the way that it is handled is you immediately put up the shields and it's battle from there on out. And that is not a healing relationship.
Two quick comments, because I realize it's late. If you read Stephen Miles' account of the interpersonal dynamics among the healthcare team, nurses, physicians, it seems that the motivating event to take this to a legal process was the report of the primary nurse taking care of Mrs. Wangley in the intensive care unit, that he had a dream one night when he was at home. This is about 2 to 3 months after she went into the coma. And the dream was that she sat up, looked around the room, and said to everyone, "Why are you doing this to me?" And this brought out these feelings of frustration over caring for her among the staff. What concerns me is that an existential assessment of futility that was purely a subjective experience of caregivers was a motivating factor to bring this. This was not an objective assessment of futility, as much as we may all agree, although really she was only 2 to 3 months into PVS, and perhaps others more expert in this area can enlighten us as to how long someone in PVS might exist with a hope of recovery. But that existential assessment of futility was the motivating factor, not an elemental assessment of objective futility. Second point, and I'll leave. The decision process that you face in dilemmas like these, I think, calls us as physicians to be willing to submit to the proper authority of the patient or surrogate in decision making. We do not have the authority to make decisions. We have the authority to prescribe, to diagnose, prescribe, and advise. Biblical submission is a model of relationship which I think we're called to, and it means that we can't make unilateral futility assessments and on that basis make unilateral withdrawal of therapy.
Thank you. Those are excellent words. And the anecdote about Steve Miles, I think is very appropriate. That is an extraordinarily subjective motivating factor, as is often the case. There is some subjective belief by the caregiver that this is inappropriate or this person doesn't have value or something along that line. And I really fear that very arbitrary nature of the futility issue.